I know. It's time. We got this, right? We got this. No. We. Right, good morning, everyone. Well, your JMP 3 students and all the other JMP students, faculty, family, and friends. Let's begin with a land acknowledgement. So UC Berkeley sits on the territory of the Hushin, the ancestral and unceded land of the Chochenyo-speaking Ohlone people, the successors of the sovereign Colonial Band of Alameda County. They have been here since time immemorial. We invite you to reflect on the fact that we reside on their land and to build our solidarity and kinship with Native peoples. We also want to begin by acknowledging the ongoing strike of units represented by the United Auto Workers. There is so much power in the collective fight for justice. We're gathering here today to celebrate our accomplishments, your accomplishments as scholars within our program, and the completion of your master's thesis. You are to be commended for your resilience, trust, and determination. Your class started fully online due to COVID-19. Your class also went through 2 heads of master's curriculum, 3 JMP directors, and just as many versions of the curriculum. You trusted that the direction of change of the JMP was profound and correct, and that trust has taken you to this celebratory moment. I am proud of all of you, and I thank you for your partnership, faith, openness, and receptiveness. So, good luck today. I want to invite Michael Lu, our dean, to give a few words.
Good morning, everyone. I want to join Gustavo in welcoming you to Paper Day. It's hard to believe that I've now been dean for 3.5 years now. Learned a lot, still learning. But one thing I've learned about speech making is that you want to stop talking before people stop listening, which I'm told for deans it's about 2 minutes. So I'm going to just say 3 things real quick. So first of all, just wanted to give a big thanks to the audience, both in person as well as those of you who are online. especially the friends and families of our presenters. Thank you for always being there for them. Thank you for always cheering them on. Thank you for all your support and love, without which our presenters would not be here today. And I hope you will also take some pride in what you're about to hear, because I believe that this is a true reflection of who our presenters are, that they're the kind of doctors that they're becoming, that their passion for making a difference in the world, and their commitment for fighting for health equity and social justice for the rest of their lives. And it's exactly this kind of doctor that we need a lot more of in the world. I also want to just take a moment to give a big thanks to all of our faculty and staff who work so hard to prepare our next generation. A special shout out to all of our thesis advisors and leaders for all your support and guidance. Peter's not here, but just really want to give a big shout out to Peter Ching Hong for all his partnership. And as Gustavo mentioned, some of you might still remember this, that for this class, I was actually the interim director for the first 6 months of my first year. And I just have to say this, that we've gone through some dark days together. And we emerged from that depth now to becoming, I truly believe, the best medical education program in the country. Has everything to do with the amazing leadership of Jyoti and Leanna and Shalene and Gustavo and Odie and all the amazing leadership. And lastly, let me just, and probably most importantly, let me just say congratulations and kudos to our amazing third-year class. This is truly a special day. It's the culmination of a lot of hard work, a lot of creativity, a lot of perseverance, and dogged determination. Right? And I know that that many of you probably haven't heard a word I said because you're like rehearsing your presentation in your head. Some of you are probably just too nervous to think right now. So I would invite you, as you come up to the podium, to just take a moment, right? Take a deep breath, take in the moment. Right? You're about to share with us like something that you care deeply about, that something that you pour your heart and soul into. You know what? No matter what you say, we're gonna love it. Because we are here for you. We've always been here for you. We're going to cheer you on. So just let it shine. So with that, I think my 2 minutes are up. And so back to David.
I'll take my mask off. So I have the unique pleasure of introducing our first speaker this morning. Now, there are no words to describe Brenda Chang. No, seriously, my mind short circuits at having to describe all of that brilliance right there. But I will try my best. Brenda hails from the state of Texas. Bless her heart. And she attended Harvard College, where she studied molecular and cellular biology because brilliance. And throughout her time at the JMP, she has made herself known to not only be our very own class dermatologist, but also our in-house fashionista. Excellent. I was hoping people would applaud at that moment. Oh my goodness, I'm blanking out right now. But no, all of that brilliance, right? So it's no surprise that her project focuses on atopic dermatitis, because if you need to figure out whether or not you have a fungal skin infection and whether or not that mustard colored cardigan is still in right now, you should probably ask Brenda, because she will know. She will know. But in all seriousness, we are so lucky to have Brenda in our program. She has helped our class in many ways, and I'm so grateful that someone like her is entering medicine. She is motivated as she is kind, patient as she is curious, and her achievements are only matched by the incredible humility that she embodies. And she's pretty hilarious. Ladies and gentlemen, everyone in between or none of the above, Brenda Chang.
Oh, sorry.
Oh, Brenda. Hello. Wow. Thank you, David, for that introduction. I feel like I've really been hyped up. I hope the presentation matches the hype. And thank you, everyone, for being here this morning and taking time. And hello to my parents who are watching virtually. So today I'll be talking about atopic dermatitis and sodium intake in the UK Biobank. So first off, what is atopic dermatitis and why study it? Atopic dermatitis is a systemic inflammatory condition with manifestations on the skin that look like these itchy, inflamed lesions. And these lesions have an unpredictable episodic pattern, so that there are flares of disease activity. And what can be really frustrating for patients and for parents, my parents in particular, is that it's hard to predict what might trigger these flares. And that's something that we're working on as a research field. Additionally, atopic dermatitis is the most burdensome skin disease globally, according to the Global Burden of Disease Study, and measured using disability-adjusted life years. Another reason to study atopic dermatitis is because it's incredibly common, and it affects up to 1 in 5 children and 1 in 10 adults. So a narrative you may be familiar with is atopic dermatitis as a pediatric disease. But what we're really seeing is that there's this increasing prevalence after about age 60 among older adults. And another important thing to notice about this graph in particular is, in addition to this bimodal prevalence where we see higher prevalence among kids and higher prevalence among adults, is that we're really looking at active disease. And so we're looking at the prevalence of people who actually have those lesions and have those symptoms and have that presentation. So additionally, we know from large epidemiologic studies that there's an increased prevalence of atopic dermatitis in recent decades. And you can see in this graph that starting from the 90s to like around 2013, there's this increasing prevalence. And we see that across all age groups, but we really see that in older adults, as you can see on the graph, above the age of about 60. And additionally, we see an increased prevalence in urban settings as compared to rural settings. And interestingly, we've also seen in other studies that people who move into urban environments also have a higher rate of atopic dermatitis than before they moved. So all of these observations kind of lead us to this question of what environmental and lifestyle factors, what are their roles in driving atopic dermatitis? What might be different about urban settings? What might be different about the recent decades? So, as indicated in my title, something that we're interested in our research group is dietary sodium. And we know from epidemiological evidence that diet is associated with atopic dermatitis, and we see that fast food consumption in particular is associated with a 20% increase in the odds of atopic dermatitis. And as many of you all may know, fast food and takeout has higher levels of salt, unfortunately. And additionally, there's some physiologic evidence that is coming from a growing body of literature on how sodium is regulated in the body and moves through different spaces. And we can see that sodium can be stored in the skin, and there are studies in mice and some limited studies in humans that show that increased dietary sodium intake may increase sodium storage in the skin. Lastly, we also see that sodium can change the local immune environment. And what I mean by that is sodium can change the way that T cells develop to promote a more inflammatory environment in the skin, and atopic dermatitis, of course, is an inflammatory disease. So lastly, perhaps some of the most convincing evidence we have is that the lesional skin of patients with atopic dermatitis, so those areas that are itchy or inflamed or scaly, have been shown to have increased concentrations of sodium when compared to non-lesional skin on the same patient or compared to healthy skin in patients without atopic dermatitis. So all of this cellular physiologic evidence is building, and we know that atopic dermatitis might be associated with diet. And so our aim in our project, in my project for this master's research project, was to look at the extent to which dietary sodium intake is associated with atopic dermatitis in a large population-based cohort, and really add an epidemiological perspective to this growing body of evidence. So the cohort we used was the UK Biobank, which is a cohort of over 500,000 participants living in England, Wales, and Scotland, and they were recruited from 2006 to 2010. Participants were around ages 40 to 70 at the time of recruitment, and we're really looking at an older age group here. And I might remind you from earlier that that's really an age group in which we're interested in learning about the increasing prevalence of atopic dermatitis and what might be driving that. So what's available in this data set includes UK Biobank assessment visits, where participants were asked questions in verbal interviews and in iPad touchscreen questionnaires, a classic of research studies, and also some clinical measurements were taken like height and weight, and importantly for our study, some biological samples like urine collection. Additionally, we have access to linked primary health records going back as far as the 1950s or 60s and following them through 2019, through which we can look for history of atopic dermatitis. And we also have access to their prescription records. So for our study, out of these 500,000 people, almost everyone, not everyone, but almost everyone had a urine sample, which we end up looking at in our study. And about half of those people, a little less than half of those people, have available linked primary health records. And after excluding people with missing data, we come to arrive at around 216,000 people in our final cohort for data analysis. 54% of the cohort is female with an average age of 57, and 95% of the cohort is white. So the exposure of interest that we want to look at is dietary sodium intake. But if you have ever tried to track your food intake or your macro or micronutrient intake, you might know that this is quite difficult to do. And it's also challenging to do from the standpoint of collecting a biological measure. The measure you might be familiar with as a medical student is the serum sodium level, but that level does not reflect dietary intake. And what the gold standard is for measuring dietary sodium intake is 24-hour urine collection. So collecting all urine over a day. And about 90% of dietary sodium intake is excreted through urine. So what's challenging about that for a study with hundreds of thousands of people is that it's difficult to collect an entire day's worth of urine. And so what we have available is a spot urine sample. So it's a single urine collection from when they visited the biobank assessment centers. So in order to estimate 24-hour urinary sodium excretion, we used these sex-specific intersalt equations that uses that spot urine concentration of sodium and these other factors, age, BMI, urine concentration of potassium, and urine concentration of creatinine. And these were shown in the previous intersalt study on North American and Western European populations. to be important factors in predicting 24-hour urinary sodium excretion. And so our outcome of interest was atopic dermatitis, as I've been talking about, and we use a previously validated 3-point algorithm for identifying atopic dermatitis. And so I went through the linked primary health records and looked for one clinical event, so one time at which a participant would have visited their primary care provider for atopic dermatitis in particular, and 2 prescription codes for atopic dermatitis therapies to define atopic dermatitis in our data set. And those therapies might be anything from a lotion or a topical steroid to something like a systemic immunosuppressant. And using this definition, around 11,000 or 5% of participants in our cohort had atopic dermatitis. And as I mentioned previously, atopic dermatitis has flares, and so we also aim to look for a subset of participants with active disease status at the time of urine collection. So we looked for a clinical or prescription code, so some evidence of interaction with their primary care provider at the time of urine collection. And using this definition, a little less than 1% of participants in our cohort had active disease status at the time of urine collection. So what did we find? We found that a 1 gram increase in the estimated 24-hour urinary sodium excretion is significantly associated with an increased odds of atopic dermatitis. And the odds ratio for that is 1.11, or in other words, an 11% increase in the odds. And interestingly, when we look at active disease, we do see a higher odds ratio. And so we see a 21% increase in the odds of active disease in comparison to just prevalent disease. So that's kind of interesting and may point us towards maybe this is a real association that we're seeing here, and certainly gives us some more confidence in what we're measuring. Additionally, we're interested to know whether there are subgroups that might be particularly salt sensitive who have atopic dermatitis. And so we looked at sex, ethnicity, and also age groups. We didn't find a significant difference for most of those groups, but we did find a significant difference by sex. And so what we see is that females seem to have an increased odds of atopic dermatitis for each increased gram of estimated urine sodium excretion when compared to males. So there are some significant limitations for this study that are important to discuss. First off, we estimated 24-hour urine sodium excretion with the intersalt equation, and we use these spot urine samples, and that is not necessarily the gold standard for measuring urine sodium, and there might be some bias from the way that we calculated it. Additionally, we took a cross-sectional approach to the analysis, and so we can't make final conclusions about causation, and there's an opportunity here for future studies to continue exploring this association. Additionally, our data set is really relatively homogeneous, with 95% of the participants being white, and of course was conducted in a different country than the US, and so there might be some limited generalizability of the results. In conclusion, we found that a 1 gram increase in estimated 24-hour urinary sodium excretion is associated with an increase in the odds of atopic dermatitis, and this effect may be more significant for females. So, could sodium reduction be a potential intervention for atopic dermatitis? As I mentioned, we can't make final conclusions from this study, but there is an opportunity for future research, such as randomized clinical control trials. And we also know that sodium reduction is an effective intervention for salt-sensitive hypertension, and it's also pretty widely used for people who have heart failure. And so it could be a feasible non-pharmacologic option for patients with atopic dermatitis that has been implemented previously for other conditions. There are so many new biologic therapies for atopic dermatitis. You may have heard of JAK inhibitors, or seen ads for Dupixent, or heard me talking about Dupixent in class all the time. But there are varying responses to these new therapies. They're effective for some patients, but not others. And diet could be a modifiable factor that helps patients in addition to these new therapies. Lastly, these biologic therapies and steroids in general address the inflammation and a lot of the symptoms of atopic dermatitis. But our hope is that the growing body of literature on sodium inflammation of the skin might help us better understand what's triggering those flares in the first place and help patients with preventing the flares. So in conclusion, I would really like to thank my primary mentor, Dr. Katrina Guevara. She's a wonderful dermatologist and epidemiologist, and my co-mentor, Dr. Van Vlergen, who's a nutritional epidemiologist at UCSF. I would like to thank the entire Guevara research group who have listened to many iterations of this project and provided valuable feedback, and Haley and Yomor in particular, who also work on the UK Biobank data set. I'd like to thank all of the faculty at the Joint Medical Program for an amazing 2.5 years where I really felt supported, and our community here, all of our classmates. And lastly, of course, I'd like to thank my funding sources from UCSF, MSTAR, and the National Eczema Association. Thank you very much. I'm happy to take any questions.
Thank you for being the first one to go. My question is whether or not there's any hypothesis for why we might be seeing this more in female-bodied participants than male-bodied participants. So if you can talk about that.
Brenda, I'm sorry, can you repeat the question into the mic?
Yeah.
Thank you.
So the question was from my wonderful classmate AC, and the question was about why we might see an increased impact in females when compared to males. First, I'll clarify that that variable in our data set is based off chromosomal analysis by the UK Biobank. And we think that it might be, well, okay. So in previous studies in salt sensitivity, they've mostly looked at hypertension. We mostly think about salt sensitivity in the context of hypertension and cardiovascular disease outcomes. And there is some evidence there that there is some salt sensitivity among females, an increased salt sensitivity among females when compared to males. So we think that might be a parallel, but this is a long way to say, I don't know. Yes, Gustavo.
Can you tell us a little more about the mechanisms, hypothesized mechanisms?
All right, so our wonderful curriculum leader, Gustavo, has asked me to talk about pathophysiology. So our understanding of sodium regulation in the body has mostly been focused on the kidneys and how the kidneys excrete sodium. And basically there's a growing body of literature that shows that there is a third space. It's not just the intravascular space and the muscles, but also interstitial space, which is the space in between our vasculature and our organs. And so sodium is getting stored there. And if anyone was in Siavash's PBL group, you may have had to read about GAGs, which are molecules in our skin that can hold on to water, but also hold on to sodium. And if you've ever used hyaluronic acid for your skincare routine, I recently learned that hyaluronic acid is a GAG. And so, anyway, all of this is to say that there is a lot of research showing that sodium can be stored in the skin, and then there's in vivo research where they put cells in like plates of sodium and look at what happens, and there is both an upregulation of pro-inflammatory pathways and a downregulation of pathways that would reduce inflammation. I hope that answers your question.
Can go to the next one.
All right.
Thank
So,
you.
can I introduce our next speaker?
Yes.
Okay. Our next speaker grew up in Houston, Texas, before attending college at Harvard University. And yes, we did know each other in college. At the Joint Medical Program, he has pursued his interests in statistics and cardiothoracic surgery, leading to his research on aortic aneurysms. As his classmates, we know him to be a great teacher, a comedian, and an expert in our statistical software. And I'm personally grateful to him for the conversations we've had about the analyses in my research. So without further ado, it is my great pleasure to introduce Siavash Zammerfor presenting temporal trends in ascending aortic diameters.
Sorry.
This is my husband, Seth Marvin, who's doing our tech support.
Yeah.
Thank you very much to my colleague Brenda for that introduction, and thank you everyone for being here. Quick anatomy review. This is the ascending portion of the aorta, which is the largest artery in the body and carries all of the oxygenated blood from the heart to the extremities. This is actually a very serious disease. This is when the ascending aorta becomes enlarged, or whenever you have an aneurysm of the ascending aorta. This has an incidence of roughly 3 per 100,000 person years, and it presents a pretty challenging risk-benefit analysis in terms of whether to pursue operative repair, which has a mortality of roughly 2 per 100, or to watch the aneurysm, at which case you may encounter a very serious complication called an aortic dissection. This happens at an incidence of 0.2 to 2.2 per 100 person years and is a very serious surgical emergency. It has an in-hospital mortality of roughly 22 per 100. The predominant risk measure to track for a ascending thoracic aortic aneurysm has historically been simply the diameter of the aneurysm. And a very recent large study, actually at Kaiser, Northern California, our neighbors, found that basically there is an escalation of risk at very high diameters, 6 centimeters or higher, which affirmed previous findings of this risk inflection point and kind of justifies the current diameter-based guidelines. But there are limitations to diameter as an absolute measure, including the fact that different people have different aortic diameters at baseline. And there have been efforts to create relative measures of diameter by dividing diameter by a person's body surface area or height, for example, by using the cross-sectional area over height, or by also incorporating aortic length into the equation. In the very latest guidelines as of only a few weeks ago, we again see a diameter-based class 1 recommendation for repair. And we also see an incorporation of growth rate into repair. So for those who are growing at a rate of 3 or more millimeters per year for 2 consecutive years, or for those who have grown at least 5 millimeters in 1 year, there's a class 1 recommendation for repair. We're also seeing for the first time relative measures of diameter in these guidelines, with the diameter indices and the area over height measures coming in at class 2A and 2B recommendations, with the caveat being that they should be done by experienced aortic teams. So the relative measures kind of start to get at this unaddressed sex disparity. Women on average have smaller aortas than men normally. But really this sex disparity continues to be unaddressed in the latest guidelines. And there are some important differences in outcomes between women and men who have ascending thoracic aortic aneurysm. So it's been shown that women have worse long-term outcomes following repair of ascending thoracic aortic aneurysms, and they also have delays to diagnosis of acute type A dissection, which is the major complication of ascending thoracic aortic aneurysms. There's also been some controversy in the literature regarding aneurysm growth rates, with estimates differing by an order of magnitude. We've seen two groups estimate growth rate at roughly 1 millimeter per year, and one of them did find a significantly higher growth rate in women than men, whereas other groups have found growth rates of only 0.1 millimeters per year. All of these studies were limited by the fact that they did not use common statistical procedures for repeated measures data, so they only looked at the first and last diameter measurements that participants had, and they just took the difference and divided that by the period of time. And actually, there are methods to account for repeating measures, such as a linear mixed model, which is what I'll be showing in this presentation. Another notable feature of these studies is that most of them were done in aneurysm surveillance populations, so people with known aneurysms and receiving imaging specifically to track their aneurysm size, which represents potential selection bias. So the main question for this study is, how do aneurysms grow in a population undergoing chest imaging for any reason, so not necessarily surveillance of a known aneurysm? And notice the how question instead of the what question, which I learned from PBL. So how do you know how big someone's aorta is? Because you can't really see it from outside their body. The good news is that sometimes radiologists will measure the aorta whenever someone is having chest imaging. And in particular, in chest CT or MRI reports, there's an opportunity to actually measure the aorta and put it in the findings of the report. So this presented opportunity to build an algorithm that systematically searches reports for measurements within key phrases that suggest that they're referring to the ascending aorta, and then determines whether the measurement is in centimeters or millimeters, and among a pool of reasonable candidate measurements, takes the maximum as the presumed aortic diameter in the ascending portion that was reported in that report. And we applied this algorithm to over 25,500 chest, CT, and MRI reports from UCSF's radiology report database. And in this database, the reports were 58% in men and 42% in women. And this 25,500 reports represents over 16,000 unique individuals. Some people have repeated measurements. In a subset of almost 7,000 scans across almost 2,000 unique individuals with repeated measurements, we were able to use a mixed model to estimate the mean diameter at the first scan and also the mean growth rate in subsequent scans. And we found that in men, the mean diameter initially was around 43 millimeters. In women, it was about 1 millimeter lower. And overall, the growth rate was about 0.2 millimeters per year. So more in line with the prior studies that have found the smaller growth rate as opposed to the bigger one. We next wanted to address the question of whether there were differences in growth rate by sex. And so by adding an interaction term to this model, we found that actually the growth rate is 0.12 millimeters in men, and women have a 0.08 millimeter increase in growth rate for a total of a 0.2 millimeter per year growth rate. And that was a significant difference. And we started to think about why this difference might be here. Both the growth rate, which is higher, and also a relatively higher initial diameter. Even though it's 1 millimeter lower in women, normally we would expect it to be 3 millimeters lower in women. And so we looked at what percentage of reports actually measured a diameter in the first place. So overall, we found that a little over half of reports measured a diameter, but there was a big difference in the rates of measuring a diameter in reports for men versus women. So in men, the rate of reporting a diameter was 51%, but in women it was only 36%. And I should add that I did actually manually review random samples of these reports. So the algorithm, this is very unlikely that it's just that the algorithm is worse at finding diameters in reports from women than men. And we next looked at predictors of having a measured diameter in these scans, and we specifically looked at age and sex as two potentially relevant factors. And as expected, we found that with an increase in age, there is an increased odds of having a measured diameter. As people age, their diameters get bigger and they're more likely to have aneurysms. But we also found that independent of age, there was a 45% decreased odds of having a measured diameter in reports in women. This is a visualization of the actual rates of having a measured diameter in the study population, which shows a consistent disparity with women having lower rates of having a measured diameter from the ages of 40 to 90. And starting to think about how this disparity might come into play, one possible explanation is that this is simply the effect of not measuring below a certain size. So this is a simulated example of what would happen if you had two size distributions with the size for men shifted to the right, and you had a radiologist who typically, once an aorta starts to look to be around 31 millimeters, starts to actually measure it and put it in their report. In this sort of scenario, you would report and measure and report a diameter significantly more often in reports in men than women. There are several limitations that are important to understand in this study. One is that the mixed model for the growth rates was done in a subset selected for having repeated measurements, which starts to get at the same limitations that other studies have when they look at aneurysm surveillance populations. There is the potential for an automated method of extracting diameter to make mistakes, and we will continue working on better quality control and finding instances when those mistakes are made. And this data reflects a single institution's radiology practices and may not generalize to other institutions. Although in general, radiologists have many sort of competing demands when they're reading an image, and it's not hard to imagine that in most places, if it looks like an aorta is the normal size, that they may not take the time to actually measure it and report it. So in summary, this study found that in those with repeated measurements, the baseline diameter of the ascending aorta was roughly 1 millimeter lower in female participants, and the diameter growth rate was roughly 0.1 millimeter per year higher in female participants. Rates of having a diameter measured and reported were significantly lower in female than male participants. And independent of an increasing trend with age, female sex was associated with a 45% decreased odds of diameter measurement. So I think there are a couple things worth mentioning about the potential sex bias in aneurysm screening and surveillance that this study may be pointing to. One is that there was a consistent disparity in diameter measurement across ages. So this isn't explained by, for example, women tending to have scans at younger ages for non-cardiovascular reasons, whereas men tend to have scans at older ages for cardiovascular reasons. There's also some evidence of this disparity being reflected in the diameter at the first scan and also the diameter growth rate. So there was a higher relative diameter at the first scan in women and a higher growth rate. And finally, like I mentioned in the introduction, we know that there are worse aneurysm outcomes in women, and this could in part explain why that's the case. If radiologists typically don't measure and report diameters in smaller looking aortas, then they won't initiate the process of surveying aneurysm size in women until they're at a relatively larger size. That could contribute to repair in women relatively later, which could lead to worse outcomes. So this presentation and project would not be possible without the help of many individuals. The Cardiac Biomechanics Laboratory at the San Francisco VA has been my scientific home at the JMP. My main mentor there is Dr. Elaine Sang, who's been an outstanding mentor to me. And other lab members who've been very helpful in this project include Dr. Liang Ga and Dr. Marco Paskovsky. I'd also like to acknowledge one of my cardiology friends, James Piricello, who gave very useful feedback on this project and actually did the study in the UK Biobank that showed the 3 millimeter difference. I also have had great mentors at Berkeley and Alan Hubbard and Maya Peterson, and I'm also very grateful to the entire faculty of the Joint Medical Program. I'm also grateful for funding from UCSF, the AATS, and the AHA. And I definitely want to acknowledge my friends at the JMP, my very supportive family, and also my partner. You know who that is. And thank you for your attention. I'm happy to take questions.
If you stratify by sex, do you see a difference or a correlation between like the aortic size and likelihood of receiving a scan or not?
Okay, so the question is, if you stratify by sex, is there a correlation between aortic size and receiving a scan more often? I think that's a really difficult question to answer because we don't know what someone's size truly is until they have a scan. Even then, as the study shows, there's a question of whether a radiologist will even measure the diameter in that scan. One approach that could kind of get at that question is to undertake these sort of like screening efforts that sometimes happen when people are approached and sort of randomly offered a scan. If we did that, we could get a less biased estimate of aortic size in men and women. And there's actually some precedent for this in the sense that people have used CTs to score coronary artery calcification and sort of screen people for MI risk in that way. And also my friend James Piricello has also now developed a predictive model of aortic size based on age, sex, and certain medical history. And so that could be applied in an asymptomatic individual who you really have no reason to think they have an ascending aortic aneurysm, and they could be offered a scan in that way. That could also be less biased in terms of sex. Yes.
Is there a possible role for the gender of the radiologist?
Yeah, so the question is it possible that the gender of the radiologist has an effect on the rates of diameter measurement? And we have started looking into that, and the short answer is that it doesn't look like that's the case. It's a pretty consistent disparity, and I think it's less likely to be a subconscious bias and more likely to be a more systematic issue where there are competing demands, and probably regardless of the sex of the individual in the radiologist's mind, they may just be thinking, if it looks small, I'm not going to measure it because I have to measure a lot of other things. And it just so happens that aortas are smaller in women. Yeah, but we need to look into that more for sure.
Thank you, Siavash. We need to transition.
Yep. All right, so it's my pleasure to introduce our next speaker, Hannah Chi. Hannah grew up, yes. Hannah grew up in Thousand Oaks, California, before continuing the family tradition and attending the University of California, Berkeley. At Cal, Hannah cultivated her passion for basic science in the Dillon lab, studying mitochondrial and ER dysfunction, spent a summer studying abroad at the University of Cambridge, and graduated Phi Beta Kappa. At the JMP, she's worked with the Feely Lou lab to understand cellular mechanisms of muscle injury and repair. She's also been a GSI, a mentor to URM students in her lab, and a coordinator for the Society for Women in Medicine. What I admire most about Hannah is her tireless work ethic, razor-sharp insight, and endless compassion and empathy, which is perhaps the influence of being raised by a surgeon and a pediatrician. Hannah's talk is on defining endogenous mitochondrial transfer in muscle following rotator cuff injury.
So, my name is Hannah, and I have the pleasure of speaking with you all today about my project on defining endogenous mitochondrial transfer in muscle following a rotator cuff injury. So I know Dean Luz said that you have 2 minutes before you lose people's attention. I'm so lucky to have 15 minutes of yours to talk about mice, so hold on, because here we go. So, just by way of some background, perhaps we'll go with some softballs. Perhaps you might remember from high school biology or introductory biology, mitochondria are the powerhouse of the cell. I think you can all say that in your sleep now. So basically what that means is the mitochondria are the little engines inside of all of our cells that are responsible for producing the energy in the form of ATP that powers us to function for a day-to-day life. So there's this rising phenomenon in the literature that perhaps mitochondria could be transferred from one cell to another. This has been a phenomenon that's been described in a variety of tissue types, including neural tissue, lung tissue, eye, as well as cardiac tissue. However, this has never been described in skeletal muscle, which might seem unusual because we know that skeletal muscle is extremely mitochondrial rich, relies a lot on oxidation to provide the energy to move us throughout our daily lives. So this is a very interesting phenomenon that we are interested in defining and exploring in the setting of skeletal muscle. And it could perhaps provide a therapeutic pathway towards regenerating injured tissues, such as muscle injury. So the particular injury model that we are focused on in this project was rotator cuff tears. The rotator cuff are the muscles in our shoulders that allow for that full range of motion. And that rotator cuff tears, which occurs over time and the prevalence increases with age, is one of the leading causes of shoulder disability in adults. What's really interesting, however, is that mitochondrial dysfunction has been linked to the degeneration of the rotator cuff following a tear. So we have this idea that the dysfunction of the mitochondria within the muscles of the shoulder following rotator cuff tear leads to things like fatty infiltration, muscle atrophy, and poor clinical outcomes. So there's this hypothesis that perhaps the donation of healthy mitochondria from other cells within the muscle might be aiding in some of the healing and regeneration that could occur inside of the rotator cuff. So where would these healthy mitochondria be coming from if we know that rotator cuff tear is associated with dysfunction of the muscle mitochondria? So now I introduce these very interesting cells that we have been studying in our lab called fibroadipogenic progenitor cells, also known as FAPs. These are a specialized type of mesenchymal stem cell that reside in the skeletal muscle. They're defined by a series of surface markers such as PDGFR alpha. These are a population of cells that are known to be very heterogeneous. There are many different subpopulations of FAPs. They've been shown to be able to differentiate into many different types of cells, including fibrocytes, which will turn into fibrosis or scar tissue in our muscle, as well as fat or adipose tissue. So I know when we think of fat, and especially in the context of muscle injury, fatty infiltration is usually associated with poor outcomes and poor muscle healing. However, there's actually a few different types of fat. Fat is a little more complicated than we might think. There's the white fat, which is kind of like the bad fat, the fat that is associated with those poor clinical outcomes, as well as beige fat, which is a much more rare subtype of fat that is also called, maybe you can think of like the good fat. Studies have shown that beige fat, which again, FAPs, these stem cells can differentiate into, this beige fat has been shown to aid in muscle healing. They're called pro-myogenic. They aid in muscle regeneration. Another interesting finding that our lab has published on is that beige fat differentiation from the FAPs can be promoted by treatment of these stem cells with a beta agonist, which is a type of drug. So putting these all together, our hypothesis for this study was that FAPs may be donating their mitochondria to the injured muscle cells in a rotator cuff injury to try to help and heal the muscle in the setting of injury. Additionally, we hypothesized that this process could be enhanced by treatment with a beta receptor agonist. Because again, beta receptor agonist, the beta treatment, has been shown to push these stem cells into this beige fat phenotype, which is associated with pro-myogenic qualities, as well as a really high mitochondrial count. Okay, so moving into some of the methods of how exactly we're going to go about answering this question. So first, we developed a transgenic mouse model. This is a PDGFR alpha crematotype mouse. What that basically means is that all of the special stem cells in this mouse have their mitochondria tagged with a green fluorescent protein So that means that when you take the cells from this mouse and look at them under a scope, the mitochondria from these stem cells are going to glow green. These mouse then underwent a rotator cuff injury, which involved the transection of the rotator cuff tendons, followed by a suprascapular nerve denervation. After the injury, the mice then underwent a treatment with mirabegron, which is a beta agonist or a vehicle control. After 2 weeks following this injury, the supraspinatus, which is one of the muscles of the rotator cuff, was harvested and then either used for imaging for our in vivo studies, or the muscle was digested and sorted through a process known as flow cytometry, and then cultured and used for our in vitro studies, as well as sent for single cell RNA sequencing. So we do a lot with these mice. They're not wasted. Okay, so moving on to some of the results from our in vitro studies. So just by way of some background, in vitro is Latin for within the glass. So this is the studies that are showing the results of our cells which have been cultured on dishes. So from our in vitro co-cultures, what we have done for these experiments is we have taken those specialized stem cells, put them on a plate next to muscle or myoblasts, which are a special type of muscle cell. So we have our stem cells laying adjacent to these muscle cells in a dish, and then we either treated these cells with mirabegron or with just standard medium. And then after 24 hours, we wanted to see if the muscle cells that were placed on the dish next to these special stem cells picked up the mitochondria that are, again, glowing green, they're labeled green, if these muscle cells picked up the mitochondria from the stem cells. And so we do this by looking at the fluorescence through a process known as, again, flow cytometry. And this graph here, just pay attention to the upper right quadrant. That quadrant is representing the muscle cells, the myoblasts that are picking up green mitochondria from the stem cells. And what we see is that after 24 hours in co-culture, there is indeed the transfer of green mitochondria to the muscle cells in vitro. Furthermore, what we saw was that this process is greatly enhanced by treatment of the stem cells with mirabegron, the beta agonist. We interestingly also saw that there was an increase in the proliferation of C2C12 cells, which are the myoblasts, following treatment with mirabegron compared to standard medium, perhaps representing some proliferative effect of the donated mitochondria, or perhaps an effect of mirabegron in the in vitro co-culture. So how exactly are these mitochondria being exchanged? So we see here that if you just put the cells on a dish and leave them alone for 24 hours, there's suddenly the appearance of green mitochondria inside of the muscle cells. So we looked at this a little bit more closely using live confocal time-lapse imaging. And we can see here that you can really appreciate just how dynamic the mitochondrial network is. So just to break this up a little bit, in green, what you see are the green mitochondria from the stem cells. The red cells are those muscle cells, the myoblasts, which are the recipient cells in this system. And I want you to appreciate, again, how much movement there is in the mitochondria. They're not latent in the cells. They're constantly fusing and dividing and moving around throughout the cell body. And really interestingly, I think you can also see, especially when you zoom in a little bit, that these FAPs, the stem cells, have these beautiful long extensions that seem to reach out and try to make contact with the muscle cells on the plate. And these extensions are extremely rich in mitochondria, perhaps suggestive of a cell-to-cell contact mediated process. So next, to quickly move into some of the results from our single-cell RNA sequencing. Single-cell RNA sequencing is essentially just a way to measure the gene expression of individual cells that are sent to a core. So what we saw is that FAPs, the special type of stem cell, following rotator cuff injury, to separate into 5 distinct subpopulations. And it's this this population 2 here. Sorry, my slides went away. Okay, got it. Okay, sorry, it's a subpopulation 2 here that is especially interesting because it's this population that is associated with enrichment of the beta receptor, which is the ADR, I wish I could point, which is this ADRB3 population here is extremely enriched, but associated with this increase in expression of this beta receptor in this population, there's also the increase in markers of mitochondrial biogenesis, as well as ATP production. Okay, so moving to our results from our in vivo studies. Remember, in vitro means within the glass, in vivo means within the living. So these are our results looking at what happens in the mice, the live mice. So we wanted to be able to quantify the amount of mitotag expression. These are the GFP tagged mitochondria that we can observe within the muscle fibers in our mice. So in these panels here, this is a tamoxifen negative. This is our negative control to prove that this is a true signal. This is not just artifact. This uninjured model, this uninjured picture here is showing just baseline expression of the green GFP signal without any injury. These are mice that never underwent the rotator cuff injury. Now, this upper right panel here is showing the side of the mouse, the shoulder that received the rotator cuff injury. And we can see that these circles that you see on this picture are representing muscle fibers. So circles are muscle fibers. The stem cells lay just wedged in between the muscle fibers in our muscles. So the circles are the muscle fibers, and in between the really bright lines are the stem cells. But what I hope you can appreciate is that we see that there are many muscle fibers here that are picking up the green tagged mitochondria from the stem cells in this injured side. But what was very interesting as well was that there was also a noticeable increase in the expression of the mitotag signal in the uninjured shoulder, so the opposite shoulder that never saw an injury, which we found was very interesting because this could be suggestive of some sort of systemic effect of the injury that is triggering the activation of mitochondria from the stem cells all over the body. Furthermore, we wanted to look at this process a little bit closer using confocal microscopy, and using confocal, we could really see how the stem cells wedged in between the muscle fibers are donating mitochondria to the adjacent fibers in the muscle. And this bottom panel here is a stain for a component of the mitochondria called ATP synthase. And we can see that in the mice that received treatment with mirabegron, that beta agonist, there is a significant increase in the expression of the ATP synthase, the mitochondrial component, suggesting that treatment with mirabegron increases mitochondrial biogenesis in vivo. So moving to our conclusions, what we have found from these series of experiments is that FAPs possess the ability to donate mitochondria to injured rotator cuff muscle in a process that is enhanced by treatment with a beta agonist. This is a process that could potentially be leveraged therapeutically with beta agonist treatment and is an exciting target for us to improve translational therapies that could improve muscle degeneration in the rotator cuff and in a variety of different injuries. Which leads us to some of the future directions of the study. Future studies should look at this phenomenon in different injury settings. In particular, we are interested in looking at this study in a hypoxic injury. We should also try to see if other cell types in the skeletal muscle are also possessing this ability to donate mitochondria. We should also investigate the unique bioenergetic profile of FAPs, and especially how their mitochondrial activities might change with age and disease settings, and tease apart the mechanisms of transfer to see whether it is truly dependent on cell-to-cell contact or if this is a cell-independent contact process. And we also should investigate whatever the systemic response is to injury that could potentially be leading to that whole body-wide response of the FAPs in activating the mitochondria in an injury. So in conclusion, I'd like to thank my co-authors in the Feely Liu Lab, especially my mentor and my co-author, Michael Davies, who has been an incredible mentor and a true role model for me, as well as my other co-mentor, who is Stephen Garcia, another resident who has been such an enormous help for me in this project. And of course, the rest of the Feely Liu Lab. I also like to thank my master's committee, Dr. Feely, who is my primary mentor, as well as Dr. Valbuena, who is my co-mentor on my committee, as well as Dr. Healy. And of course, I'd also like to thank my JMP family. I know, as you can tell, I like GIFs, so a lot of GIFs in the presentation. So I'd like to thank my JMP family, whose silliness and lightheartedness I don't think I could have ever survived this wild process with. Of course, my real family, who may be watching on Zoom, except for my sister, who's taking her OB-GYN shelf as we speak. And of course, I'd like to thank my partner, Josh, for his enormous support and letting me talk his ears off about mitochondria for, who knows, the past 2.5 years, I suppose. And of course, I'd also like to acknowledge the UAW strike that's occurring right now. As Siavash mentioned, I'm a GSI. I have been working as a graduate student instructor for over a year now in the university. And I would like to just express my solidarity and support for the UAW and the demands for a fair and livable wage for UC workers system-wide, postdocs, as well as residents who are also protesting at UCSF as well, and all people in the UC system and beyond. So thank you, everybody. Yes, David.
Excellent presentation. I'm curious if there has been or if there will be work looking at whether or not these outcomes are correlated with qualitative assessments and improvements in mobility in the mice?
Yeah, that's a great question. So one of the things that we are trying to develop in our lab is, oh, sorry. Okay, so the question is if any of this has been, if there is a functional outcome that could be correlated with the with these like processes that we're studying. So something that our lab is trying to develop right now is a way to measure the ability of mice to pull on a string in a cage, which is so interesting. You literally put them in a little glass box and you give them a string with a Cheerio on the end, and then they pull it. And we use a video camera to record them pulling. And the idea is that we want to record the motion of their arm, because a rotator cuff is a shoulder motion. Right now, what we have are DigiGate, which is a way of measuring mouse steps on a treadmill. It's all very cute, which is why I hate working with mice, because obviously you need to get the muscle somehow. But so basically we have not yet been able to validate a functional component to this. I can just say observationally, the mice are really messed up after getting the rotator cuffs torn. But after 2 weeks, there's an improvement. But to quantify that, we are trying to work on this string pulling assessment, which has been going slowly. I don't think they're very motivated by Cheerios or Jozos. I think they need Fruit Loops or something.
Thank you.
Yeah. Yes.
Can FAPs be expanded in vitro? Could they be transplanted? And just thinking of translational implications.
Yes, actually. So another thing that we're trying to work on. Okay, so the question is if you can implant these cells in vitro, for these in vitro cells in vivo to try to kind of implant these FAPs. Is that the question correct? So a couple things is that there are huge FDA regulations that basically say that once you take a cell out of a body and put it on a plate, you cannot return it to a living organism, like a human. You can in mice. So what we have been doing is that we've been working with the Healy lab. Dr. Healy is one of my co-mentors in developing a special matrix called a hydrogel that you can inject and hold cells in a muscle with. And so we're trying that out right now. We're having some issues being able to track the donor cells once they've been implanted into the muscle. So that is something that we're working on, is that potentially using a hydrogel, which again is like a matrix that is made of hyaluronic acid, as Brenda talked about, that will hold the cells and keep them happy, and could potentially be a therapeutic way that we can leverage FAPs and their intrinsic abilities to improve muscle outcomes. Right on?
Yes, I understood correctly. You mentioned how on the opposite shoulder rotator cuff muscle you see kind of like an increase in like response. Is there like a theory behind why that is that you may be familiar with?
Oh, you can get me going. Okay, so the question was if there's a theory as to why we're seeing this contralateral response or increase in the GFP expression in our mouse models. So what we are our current hypothesis is that following this insult, even in a very acute and direct area of the body, there is obviously a system-wide response to this huge injury that we're inflicting onto the mice. And so that there could be some sort of circulating factor, like through the blood, for example, an inflammatory marker, a cytokine, or there's emerging literature in something called mitokines, which are mitochondrial-specific signaling molecules that could be responsible traveling through the blood and signaling muscles all over the body to upregulate their response to an injury. Because even though just maybe one shoulder is messed up, your whole body has to respond to be able to pick up the slack. So this is not something we've quantified necessarily, but just observationally, there does seem to be a clustering effect almost of where we observe the increase in mitotype expression around blood vessels in particular. So that could also lend some anecdotal evidence that this is the result of circulating factors, perhaps.
Thank you so much.
with that being said, I have the greatest honor and greatest pleasure to introduce our next speaker, who is Mare Clashman. Mare was born and raised in Los Angeles and went to Washington University in St. Louis, where she majored in biology and Spanish with a minor in anthropology. And while at WashU, Mare was deeply involved in virology research and investigating the Ebola virus and its processes of replication. She's truly a master of all trades. She was also involved in community service as well as mental health advocacy while at WashU. But after graduating, Mare worked full-time for the city of San Francisco in improving industrial hygiene trainings as well as improving disability services in the city. Mare then went on to bless UC Santa Cruz with her immense talents and ability, where she helped to set up a new lab and launched UC Santa Cruz's very first zebrafish housing system. Incredible. I know, she just impresses me every day. But at the JMP, Mare has been devoted to and intimately involved with organizing around issues around environmental health as well as reproductive health. As her classmate, I'm constantly awed by the breadth of knowledge and exceptional warmth that Mare brings to every single space that I have been so lucky to share with her. At the same time, Mare's ability to center the human experience and focus on social justice is such a powerful asset that she applies to everything that she does. So without further ado, I welcome Mare to the podium to share with us her incredible work over the past few years titled Shoreline Monitoring of Illness Risk from Contaminated Recreational Waters. Has UTI been overlooked? So today I'll be presenting on, as Hannah mentioned, shoreline monitoring of illness risk from contaminated recreational waters, and specifically asking, has the UTI been overlooked? So I actually wanted to start with my acknowledgements and by thanking my research team. Without them, none of this project would have been possible. So first I wanted to start by thanking my undergrad team, Daniela, Jenna, and Sarah. They were literally involved in every part of this project and I learned so much from them. I also wanted to thank my PI, Jay, for his incredible guidance throughout this, this process. And you're seeing a picture here at the bottom left of Jay helping me enroll participants. It was the hottest day of the summer, so I'm so appreciative of him. And I also wanted to thank Lee Riley, who really shaped my project in so many ways and challenged me to ask more meaningful questions in this work. And then finally, I wanted to thank the JMP exec team for their years of support that is culminating today. So this project focused on bacterial contamination of marine waters, which can happen through a few different mechanisms. First, through what is known as point source contamination. So this is where bacteria is directly discharged into the water. So something like a treated sewage pipeline is considered a point source. It directly deposits fecal bacteria into the ocean. And the remaining contributors to bacterial contamination include things like agricultural runoff, industrial runoff, freshwater discharge, local wildlife. And so these are things that increase the levels of fecal bacteria in the water, but not through as much direct deposition into the water. So there are known risks to swimming in waters with this kind of fecal contamination. So we see here that the incidence of things like GI illness, respiratory illness, ear infection, eye infection, and skin rash all increase with water exposure, and particularly with head submersion and swallowing water. I'd also like to point out that the illness with the highest incidence at all levels of exposure is diarrhea. So we can also analyze the risk of these illness events from different levels of swimming, and we find that diarrhea not only has the highest incidence, but also has a really clean dose respondence risk. So the higher level of water exposure, the higher risk of getting diarrhea. So it's really for this reason that gastrointestinal illness, and specifically diarrhea, is universally recognized as the riskiest result of swimming in contaminated water. So in order to prevent these outcomes, local government agencies will warn the public when their risk of illness is high through signage at beach entrances. So these are actually photos from our study sites on contamination days. So local water departments will determine the risks that their beaches pose to beachgoers through bacterial analysis. So a water quality lab will pull samples from the water along the shoreline and analyze for what are known as fecal indicator bacteria. And so these are bacteria that co-vary with levels of feces in the water and therefore fecal pathogens. And so these specific bacteria are selected because they're particularly easy and fast to quantify, so you can get a quick result on contamination. So the EPA has conducted several epidemiology studies to determine the level of bacteria above which GI illness is at its highest. So the risk of GI illness is really the common barometer because it's considered the highest risk of swimming in these waters. And so if the bacteria levels that the city has analyzed in their samples exceeds the thresholds that you see here, they are required to notify the public through signage. Something I want to note about these thresholds is they're set at the amount of bacteria at which about 3.6% of swimmers would still get gastrointestinal illness. So they're not perfect at preventing illness, and this is the standard that we follow. So we saw previously that these fecal bacteria can cause infections throughout so many different systems. However, we know fecal bacteria to cause another kind of infection, which has not really been explored in this context, and that's the urinary tract infection. The pathophysiology of a community-acquired UTI is conceptualized as this process where bacteria that are commensal to the GI tract make their way to the urethra through some sort of breach where they can then cause a UTI. So in about 70 to 90% of cases of the community-acquired UTI, the bacteria that's responsible for this is known as a uropathogenic E. coli. So this is a type of E. coli that exists within the gut without consequence, but if it is exposed to the urinary tract, it can cause significant disease. The remaining organisms that are responsible for UTI, which are indicated by this pie chart, are also considered fecal bacteria. So people who were assigned female at birth are particularly vulnerable to the UTI due to having a shorter urethra. The urethra is more proximal to the rectum. However, an individual's genetics, anatomy, and engagement with things like antibiotics, catheters can increase their risk of UTI. However, what we often hear colloquially about the risks for UTI are behavioral factors. And so sexual activity is the most evidence-based behavioral risk of UTI. However, we often also hear about things like direction of wiping. Both that and sexual activity are thought to bring the individual's own fecal bacteria forward to the urethra. And we also hear about things like lack of postcoital voiding or dehydration, which are thought to create an environment that's ideal for colonization by these bacteria. So we know that the pathogens responsible for UTI are coming from fecal matter, but do they also exist in fecally contaminated waters? The evidence has shown that waters that receive treated sewage have measurable levels of these uropathogens, and some with antibiotic-resistant properties. We actually know very little, though, about what the actual risk of swimming in these waters is for contracting UTI. There was one population-based case control study that was performed in 2015 that set out to determine several different risk factors for antibiotic-resistant UTI. And they assessed for many variables such as travel, eating habits, and hygiene habits, but they also took a look at swim exposure over the course of a year, and they examined it as an independent risk of antibiotic-resistant UTI. So we see here that among the different kinds of swim exposure, swimming in seawater produce the highest and most significant risk. We also know UTIs to consistently occur most often in the summertime, particularly in the month of August. And this is across different age groups. And so this is also a time where many people tend to seek out recreational water activity. So of the many prospective epidemiology studies that have tracked the health of individuals after they swim in contaminated waters, only one has accounted for the UTI, and it was in their supplemental section. So this study did use a sample population that was 42% under the age of 18 and 47% assigned male at birth. So unsurprisingly, the results were not significant in a population where UTI is rare. So we conducted a prospective epidemiologic study in Santa Cruz, California to track the health outcomes of people who were assigned female at birth and assess for the risk of UTI from water and sand exposure. We also wanted to know what kind of exposure causes UTI. Is just soaking in the water significant enough to cause bacterial exposure and ascent up the urinary tract? So we collaborated with the city and county of Santa Cruz to also perform water quality analysis on the days that we were enrolling people into the study to help us determine the level of contamination most associated with those outcomes. So this figure shows the entire coastline where we recruited participants, and you'll also see with the shapes along the coastline, that is where water quality samples were taken. And I just want to point out that there are a few different sources of contamination at this site. So there is a treated wastewater pipeline that discharges about a mile offshore. And we also see the river at the top right. I don't know if you can see my cursor, but that's known as the San Lorenzo River, and it is considered a non-point source. It's a freshwater source that has a great deal of wildlife, but also receives some untreated septic fluids, and so it can be in some ways considered a point source as well. So we began by approaching beachgoers to enroll in the study over the course of the summer of 2022 and assessed for their eligibility. We required that they had not swam in an ocean or a lake in the week prior, and we pre-stratified, as I mentioned before, the study population to people who were assigned female at birth and to really capture people who were disproportionately burdened by UTI, and we also stratified to adults. So if the eligibility criteria was met, participants were enrolled, and we also captured, using survey devices, the geographic location where they were enrolled so we could track them to the closest water quality sampling site. That evening that they got home from the beach, they were asked to complete a first online survey where they answered questions about their baseline health and what water activities they did that day. And then finally, 2 weeks later, beachgoers completed a final follow-up survey where they indicated the symptoms that they experienced since they went to the beach. Consistent with prior studies, we classified someone as having a highly credible gastrointestinal illness if they had any of the symptoms listed above, or listed under HCGI. And then we also classified someone as having a UTI if they had 3 or more of the typical UTI symptoms. In addition, they could not have a menstrual period or be experiencing vaginal irritation or vaginal discharge. For any of the participants who indicated that they had symptoms in the days prior to going to the beach or on the day of their beach visit, they were excluded from the analysis for that outcome. So you can see here, there was quite a bit of contamination at our study site this summer. This was one of the days where the entire shoreline was under a health advisory, and this was for multiple indicator bacteria where you can see they're very far out of range. In total, there were 58 violations on days where we were enrolling people into the study, which made up about 15% of all of the water quality samples. And this was actually distributed pretty evenly across the study sites and across the enrollment days. So we first analyzed the incidence of gastrointestinal illness, which is HCGI, and UTI within different exposure groups. It was pretty clear that the more exposure, there was a greater proportion of people who were becoming ill with both gastrointestinal illness and UTI. We then analyzed the risk of illness, which is represented as the adjusted odds ratio, through a logistic regression where we also accounted for confounding covariates for the different outcomes. So we found that water exposure increased the risk of both UTI and gastrointestinal illness here as well. So we actually, interestingly enough, found that the risk of UTI from swimming increased with progressive exposure. So from waist deep to head underwater to swallowing water. So the highest risk of incidence of UTI, the highest risk and incidence of UTI was incurred by swallowing water. We also had a few incidental findings. We found that people who wore wetsuits or people who showered on site only accounted for less than a quarter of the people with gastrointestinal illness and UTI. So it's our hope that future studies, potentially with larger cohorts, should interrogate the efficacy of these protective precautions. We also found that of the people who swallowed water and then experienced UTI during the study period, they also experienced diarrhea during the study period, and that occurred prior to their UTI episode. Another thing we found was that 50 people, which is about 8.5% of the study population, opted not to swim after they talked to the study team. I have no idea why. But on an anecdotal note, we also found that many people, especially on contamination days, were not aware that there was a health advisory sign up. They didn't see it. And so the fact that they changed their mind after talking to the study team offers a potential opportunity for a public health intervention for maybe more effective ways to communicate when the water is contaminated. So the findings from the study offer us a potential model of UTI from contaminated water exposure. So we start with the fecal contamination from point and non-point sources, which we talked about at the beginning. This leads to bacterial contamination of the receiving water. And these bacteria do become more diluted in a large water body. And then these bacteria can evolve in their aquatic environment through sharing genetic material. We then see that humans are exposed to these bacteria by swimming, particularly through the riskiest contact, which is swallowing water. We think that the uropathogens that an individual has swallowed can then colonize the gut. And in the gut, the bacteria can continue to evolve. And these gut bacteria that are uropathogenic can make their way to the urethra through some of the mechanisms we discussed earlier. And we see a urinary tract infection. So what this model that's resultant from the study really calls into question is preconceived notions about the UTI. The risk of oral ingestion tells us that UTI can't solely be attributed to these behavioral risk factors that we often cite as causes of UTI, but rather contamination in the environment. This has significant implication for contaminated drinking water as well and the risk that that might incur. We also observed that participants who swallowed water got diarrhea and then UTI in many cases. So we should consider the gastrointestinal illness as a result from swimming in contaminated water as a potential additional risk factor for UTI. So my work on this project isn't done. I will continue to assess the association between the fecal indicator bacteria levels and UTI rates. During my time doing this work, I also heard from a few moms who had 16 and 17-year-olds who were not eligible for the study because they were too young, but did also get UTIs after swimming. So my hope for future studies is that they can include an adolescent population and also be able to confirm UTI through culture methods. So yeah, I want to thank my funding sources, my family and my JMP family. And then I also want to stand in solidarity with the grad student workers who are striking today and implore people who are here today to show solidarity through a strike support fund or the petition to the UC president.
I'm afraid to ask this question, but since your study focused on saltwater, what does this mean for like fresh water?
Yeah, that's a great question. I think that a lot of those fecal contamination sources are present in freshwater sources as well. I think that this is actually where salt comes into play, and it's been previously thought that salt might be not as ideal of an environment for bacteria to grow, but there are also just a set of different pathogens in freshwater. And so I would say it is definitely an opportunity for future study. And if you were to go swimming in freshwater, these same signage rules are in place as well. So like anywhere where people might be recreating, at least in the state of California, there will be signs up. Sorry, I forgot to repeat the question.
I think we need to stop now.
Oh.
Thank you. We'll be on break until 10:20. Okay?
Yes.
Hi everyone, I am so excited to introduce my friend AC. I wanted to share a little known fact about AC, which is that she's from New York City. And after that, she went to Cornell University, and after graduating college, she became a case manager and Spanish interpreter at MSK, and then was a Fulbright scholar in Spain. So something that I admire so many things about AC, but I think something that really encapsulates what I admire about her so much is I've gotten to share a wall with her for the past few months, and I hear her tutoring people in epidemiology. And I think I hear her patience, her clarity, and the way that she meets people where they are without any judgment. She's done so in helping me with my own project, and I think it just really encapsulates how she moves about the world and has moved about a lot of us in this program. I love her adventurous spirit. She's one of the funniest people I know. And she is just an amazing conversationalist. I feel like I can talk to her about anything and enjoy myself and come out of it learning something new. She also asked me to tell everyone that she smells nice. But anyway, I'm so excited to hear about your project and also to continue to learn from you. Thank you.
To clarify, I said that when I blanked about a fun fact about myself. So, thank you, Mary. Hi, everyone. So I'm going to present today my project on the retrospective analysis of wildfire smoke exposure and birth weight outcomes. My primary mentor was Dr. Amy Padula from UCSF. So just to set the groundwork a little bit, I'm going to delve into the background of wildfire smoke and pregnancy outcomes, then present my research question, go into my methods, report my results, give you a short tidbit on the analysis, and then acknowledge all the people that helped get me here. So a brief history of wildfires in California. Wildfires have been a reality of living in California, but the number and intensity of those wildfires measured by the sheer number of acres burned each year has quadrupled in size in the last 4 decades. For context, of the 10 largest wildfires in California history, 8 of them have occurred in the last 5 years. And the Dixie Fire, which burned in July 2021, was the largest single source wildfire in the history of California. And we can't really talk about wildfire and health effects without introducing particulate matter. PM2.5 is a term we use for particulate matter that is less than 2.5 microns in size. Because that's a really hard thing to imagine, just to put it in context, PM2.5 is a fraction of the width of a strand of hair or a grain of sand. It's really, really tiny. And because of how small it is, it has the ability, when inhaled through our mouth and our nose, to wreak havoc on different organ systems. Of note, PM2.5 has been implicated in different medical conditions by the CDC, including heart attacks, arrhythmias, aggravated asthma, decreased lung function, cancer, and reproductive health as well. And my project focuses specifically on PM2.5's effect in pregnancy. And as many of you know, developing fetuses depend on parental blood for access to oxygen, which is essential to their development. And recently, researchers have found that PM2.5 actually has the ability to cross the placental barrier. And in doing so, we think that it inhibits the proliferation of placental cells, disrupts nutrient transportation, as well as alters inflammatory mechanisms and cell-to-cell communication in the fetus. Researchers have also found that PM2.5 affects on developing fetuses appear to be sex dependent. So male fetuses tend to be more vulnerable to fetal demise than female fetuses, and in the context of maternal stress. And we think that's because male fetuses tend to increase metabolic activity, while female fetuses conserve growth in times of maternal stress. And my research project focused specifically on birth weight. Why do we care about birth weight? Mostly because there have been many studies to suggest that there's a correlation between neonatal birth weight and health outcomes later in life. Specifically, babies that are born small for gestational age, aka under the 10th percentile for weight, have been shown to have increased risk of cardiovascular disease, cancer, respiratory illness, and chronic metabolic conditions later on in life. And on the flip side, babies born large for gestational age or in the highest 90th percentile are at risk for trauma secondary to vaginal delivery, like shoulder dystocia and hypoglycemia, independent of the diabetic status of the birthing parent. The literature on the effect of PM2.5 exposure and birth weight has, to put it bluntly, been inconclusive and kind of a mess. There have been studies that have shown reduced birth weight and increased birth weight when it comes to exposure to PM2.5. There was a review by Amjad et al. Last year that found that there was a temporally specific outcome to exposure in the second and third trimester. Basically, that low birth weight was correlated to exposure in these 2 trimesters, although the review stated that there was low certainty due to the limited ability to capture the actual extent of exposure to wildfire-specific PM2.5. And then an Australian study that came out a few years ago found that there was actually increased birth weight following wildfire smoke exposure, and that this was sex-dependent, that males had a higher risk of being born large for gestational age. But it's important to note that a limitation of the study was that they didn't control for gestational age at birth, meaning they were only looking at full-term babies. So to introduce my research question, I am trying to delve a little bit deeper into how wildfire-specific PM2.5 affects birth weight outcomes, and trying to use methods that, address some of the limitations of previous studies. So in order to understand the methods, I'm going to talk about my data sets a little bit. Our exposure data set was actually prepared by Aguilera et al. In 2021, and it was a statewide wildfire-specific PM2.5 data set. So it excluded PM2.5 from other pollution sources, so car exhaust and industrial sources. And that allowed us to really isolate wildfire-specific PM2.5 in our study. And it was also interpolated at the zip code level, meaning that we, for the last 10 years, have the zip code level of PM2.5 for every day of the last decade, which was really advantageous to us, and we're really grateful for this research group. Our outcome data set and how we extrapolated birth weight was we took the UCSF EHR records from Betty Irene Women's Hospital and converted birth weight to gestational Z-score in order to adjust for gestational duration and look at a wider range of babies born at the hospital, not just full-term babies. And we excluded non-singleton pregnancies, so twins, triplets, smokers, and women who gave birth after March 13th, 2020, which was, as we are all familiar with, the day that the world shut down due to COVID-19. And we also excluded transfers, meaning women that were transferred to UCSF, usually because of a labor or delivery emergency from a different site. And our model adjusted for age, race, not as a biological factor, but as a proxy for potential discrimination and level of education. So we took this EHR record, we determined gestational trimesters, and then we got this wildfire exposure data set, got the PM2.5 levels and assigned them to each zip code in the Bay Area for every day of the last 10 years. And then we assigned PM2.5 exposure to each day of each pregnancy that we had on file. And then we performed linear and logistical regression models. Linear regressions looked at the continuous variable of gestational z-score, whereas logistical regression models that we ran looked at specifically the categorical variables of small or large for gestational age. And then we performed these regressions again in sex stratified data sets. So stratified by male and female fetuses, and performed a chi-squared analysis to determine sex differences in response to wildfire smoke. Our study ultimately, after excluding everyone who didn't meet the criteria, was 7,900 or so pregnancies. The majority of our study was white and college educated. 96.6 had private insurance, and the newborn sex was split kind of 50-50 between female and male. Our results showed that in our linear regression analysis, that exposure to wildfire-specific PM2.5 in the second trimester was positively associated with increased gestational z-score. This was the case when measured both as an average PM2.5 throughout that trimester and the number of days that PM2.5 exceeded 5 micrograms per meters cubed in the second trimester. Our logistical regression analysis also supported this. There was a positive association between exposure in the second trimester and large for gestational age births. And concordantly, there was the opposite effect in the SGA analysis, the small for gestational age analysis, meaning that there was a negative association between being exposed to the wildfire smoke and being born small. So taken together, this research seems to suggest that being exposed to wildfire-specific particulate matter in the second trimester especially is associated with being born with increased birth weight. And that was seen in our analysis with LGA and SGA births, and that they were concordant with each other. And it is supported by a paper written by Rasmussen and the team that found that birth weight is correlated most highly with fetal weight gain in the second trimester. And it's important to note that our results are completely contrary to many previous studies that found an inverse relationship between wildfire smoke exposure and birth weight outcomes. And there are a few reasons why we think that is. The first one is differences in our methods. So traditionally, studies that have looked at this question have used single air monitors to sort of extrapolate PM2.5 levels for an entire swath of land. And that doesn't really take into consideration, especially in a place like the Bay Area, topographical differences, meteorological differences, hills, wind, ocean, all these other things that can affect what the actual PM2.5 is that people are breathing in. And our exposure data set was able to do that. And it was also able to be really specific for every zip code in the Bay Area. The next difference is between our study and previous studies is demographic limitations. So UCSF serves a primarily privileged population. This study was done in majority white and college educated study participants, and it's not representative of the general population. And in fact, we think this might have affected our results because given the relative privilege of our study population, it's possible that our subjects were afforded the luxury of staying home when air quality was bad, and that could have actually been protective for birth weight outcomes, or they might have been able to leave the Bay or afford air monitors. So future research on PM2.5 and birth weight outcomes should focus on isolating PM2.5 from other pollution sources. We feel like we did this pretty well. One thing we didn't do really well is use a cohort that was representative of the general population, and further studies should do that. And the last thing is that further studies should explore causative mechanisms for birth weight deviation after wildfire exposure. We have an idea of what's going on with the inflammatory mechanisms, but no one's actually sure. I'd like to finish by thanking my primary mentor, Dr. Amy Padula, who mentored me from Germany this entire time. We've never met in person, but I'm extremely grateful to her. She met me. She met me when I had never learned how to code. So this is the first time that I had tried writing a code. You can see I was #failing the entire time. Next, I would like to, how do I get out of here now? 1 second. Okay, next I would like to thank my family who couldn't be here today, who, as Meredith put it, is on the East Coast. Specifically my parents. My sister Sarah, Chris, Tia, and my abuelos who died before I went to medical school, but who I think of every day and who are my inspiration. And then next, I would like to just thank the family that got me here, that are not blood related, but are my family nonetheless. A particular shout out to Jen and Brenda, who were my landing pad when I moved here and who helped create a home for me here, and for Mare, Jessa, and Anne, who quite literally took me in this semester, and as well as my family back home, my girlfriend Amanda Leon, and all my friends who have supported me in this project. Thank you so much. Take questions. Yes.
It would be really interesting to know if you can get data from areas that are closer to the wildfires themselves to see what kind of information you might get from for work outcomes. Was there any work on that, or?
I think I heard the question, which was that sorry, I'm a little hard to hear.
Plans for, or can you look at or get data that are exploring sources closer to the actual wildfires themselves, rather than from a distance in the Bay Area?
Yeah, there are a lot of studies actually on that now. In the last few decades, the people living on what they call the wildfire urban interface has increased a lot, and I expect a lot of research to be focusing on that coming out very soon. There's been we focused on the Bay Area just because of the sheer density of people here and the fact that it was easy to get the EHR records from UCSF Health Center, but that is definitely something that I think people will look into in the future. Yeah, Hannah.
That's incredible work, you guys, amazing. Could you explain how wildfire PM 2.5 is different than like the other PM 2.5 you might be exposed to, like the lake wildfires?
Yeah, so okay. Yeah, so very briefly, when wildfires burn, it's typically timber and other sources, like organic sources, that are thought to be different in composition from, for example, the PM 2.5 that's released in car exhaust. PM 2.5 is just like a measure of particulate matter, so it's just basically fine particles. And that they can have compositions of many different things. With wildfires, we think it's more organic materials unless it's encroaching on the urban wildfire interface.
Okay. Thank you so much.
So I have the pleasure of introducing my classmate and friend, Jennifer McKinnon-Krems. Jen hails from Pacific Palisades, California. She majored in economics at Amherst College and then went on to conduct gastroenterology research at Mass Gen and work as a 4th grade teacher in Puerto Rico before she joined us at the JMP. What I most admire about Jen is her ability to challenge her friends, aka me, classmates, and systems around her. She pushes us to think beyond conventional structures, be critical of oppressive systems, while all along being a loving plant mom, cat whisperer, and a fierce friend. Please welcome Jen.
right. Hello to people here and people on Zoom. Thank you so much for coming and supporting us here. So my master's thesis is called Money and Place, quantifying the types of obstacles associated with seeking an abortion after 10 weeks gestation. And I did this research as a part of my thesis for the joint medical program and also through Answer at UCSF. And my primary mentor was Lauren Ralph, and my other mentor was Susan Ivey, who helped support me in this work. So let's start with the context of where we are now. As many of you, if not all of you know, this past June, the Supreme Court overturned Roe v. Wade with the Dobbs decision, and so functionally lifted the protections on abortion federally. And this resulted in a lot of bans occurring all across the US. You can see in the upper right corner from a few weeks ago, the abortion bans that popped up, both full and partial. This was a few weeks ago, so now Georgia's ban is blocked, but it's unclear how long that block on the ban will last. And then below, you can see the post-midterm result of further restrictions that are expected to happen. And this essentially makes it so that hundreds of thousands of people in the US who want an abortion are now living in a place where they cannot receive one in their state. And this particularly impacts facility-based abortions, so abortions where people need to go into a clinic. And so it really asks us to think about virtual ways, telehealth ways to expand access in this time that we find ourselves. And so why do these abortion restrictions matter? Maybe you think they matter just as an essential health service in their own right, but I also want to talk about some of the downstream effects of what happens when people are denied a wanted abortion. There have been large national studies that have looked at the financial consequences of people who are denied an abortion and compared them to their counterparts who receive an abortion. And they find that for years after the abortion is denied and the person is forced to remain pregnant, they have lower credit scores, higher rates of debt, their family is more likely to fall below the poverty line. And again, these consequences persist for years. They also find that there's an impact on education outcomes. People who are denied a wanted abortion are less likely to achieve higher educational degrees. And these both have really big equity and social justice impacts because we know that the majority of people seeking abortion in the US are poor and people of color, which is largely thought to be because of how inaccessible contraception is. And so the financial consequences and the educational impacts are disproportionately falling on people who are already oppressed by US systems of power, and furthering these equity issues that our country faces so really every day. And so going into this study, we know there are a lot of barriers to care, even before the Dobbs decision. There are geographic issues. In 2017, they found that there are 27 regions in the US that are called abortion deserts. This is a place where there's at least 100,000 people living who live over 100 miles from the nearest provider. The average amount of mileage that people travel one way is 40 miles to get to their provider. And then there are various legislative restrictions. So waiting period laws, there are legislative restrictions that limit clinics, limit providers. There are also immense financial costs to getting an abortion. For medication abortion, it's usually about $400 to $500. For a procedural abortion, about $600. And these services are often not covered by public or private insurance. So this is an unexpected out-of-pocket expense that people are expected to pay. And so our research question going into this was what types of barriers are associated with presenting after 10 weeks gestation. And we're looking at 10 weeks as a marker because this is the limit to where the FDA approves medication abortion. So after this After this date, then people likely just have procedural options, and particularly if you're living in an impacted state, you can no longer receive an abortion in your state. You're going to have to travel, and so we wanted to look at this marker of time. Additionally, abortions get more expensive later in pregnancy, and so they become increasingly inaccessible. And so what did we do? We surveyed over 1,000 people across the country. This data is from 2019 and 2020. And we surveyed people in Alabama, California, Florida, Illinois, North Dakota, Texas, and DC. So a wide variety of sociopolitical contexts. And then we asked them specifically 11 questions about certain barriers and whether or not that delayed their access to care. This next chart is going to be broken up onto 2 slides so that you can see it better. These are the direct questions that we asked people in the survey. You can see that getting money to pay for the abortion was the most common. 30% of the sample experienced that. And then we grouped similar questions together. So money to pay for travel and money to pay for abortion were grouped together as financial barriers. We then also asked about questions that we grouped as geographic barriers, so ability to find a place, ability to get to a clinic, whether the doctor could schedule you or not, which often is going to be based on a large demand in a place, a clinic that serves a really large population far and wide. It'll be harder to schedule there. And then these are some of the other questions that we asked. We asked about specific legislative barriers, so waiting period laws, for example. And then we also asked about personal logistical barriers that might have delayed access to care, which also might intersect with some of the legislative barriers that we know. We found that over half of our sample experienced at least one barrier. We found that almost 20% experienced 3 or more barriers. So this is potentially up to 11 based on the questions that we asked. This is the groupings that we did. So about 1/3 of the sample experienced barriers within each of these groupings, financial barriers, geographic barriers. And then for our analysis, we limited our sample to those for whom we had gestational duration confirmed on ultrasound. And then we did a logistic regression to determine which barriers were most associated with presentation for abortion after 10 weeks. And we used fixed effects for site because we know these sites are super different from each other. We also controlled for age. We used race and ethnicity as a proxy for racism. We used language spoken at home as a proxy for ease of system navigation, knowing that a lot of these clinics are English language and American centric. We controlled for past pregnancies, sociodemographic characteristics, and then the legislative climate of the participant's state of residence. So we had zip code for all of these folks. And then we also performed some sensitivity analyses. We were curious to see, did our results hold up when we looked at this question a little bit different? So we also looked, instead of at 10 weeks, we looked at 13 weeks, the end of the first trimester, which we found our results were consistent. We also, instead of grouping barriers together, the financial barriers together, the geographic barriers together, we also looked at barriers like as a summative measure. So between 0 and 11, you got a score of how many barriers you experienced, and we were also consistent when we looked at things that way. Who was in our sample? The median age was 26. People were between 15 and 45. Our sample was 35.4% Black, 30.9% non-Latinx Hispanic white, 18% Latinx Hispanic. And then we had really good granular data on ethnicity for folks, for example, within the Asian grouping, but we didn't have the numbers to deaggregate that data. And so these percentages that are low are just hard to interpret, and further work needs to do a better job of answering those questions. And then about over 1/3 of our sample were poor. We looked at this various measures to assess that. Median one-way distance to the clinic was 20 miles, And over 30% of people in the sample traveled over 50 miles to get their abortion. And then 50% of people lived in states considered hostile to abortion. This was a measure that was created by the Guttmacher Institute, where they looked at 6 different policies, both supportive policies and restrictive policies, and then gave states measures based on how restrictive or supportive they were for accessing abortion care. What did we find? So we found that geographic and location barriers and financial barriers were statistically significant with presenting for care after 10 weeks. The way you interpret this is, for example, the geographic location barriers piece. If somebody experienced one of those barriers, then they were 1.86 times more likely to come in after 10 weeks. And then for financial barriers, they were 1.69 times more likely to come after 10 weeks. And within all of our covariates, so all those things I talked about that we controlled for, the only thing that was found to be significant was difficulty meeting basic needs, which was the socioeconomic measure that we used. All of the other covariates were not found to be significant. Then wanted to look at what is the case in supportive states. We know that the bans are restrictive. We know that there is intentional restrictive legislation, but what does it look like in states like California and Illinois, which were our 2 supportive states for abortion care? And we found that there are still significant geographic and location barriers that people are experiencing, and that difficulty meeting basic needs is also still statistically significant. And so as far as our conclusions, as far as what this means, again, all of this data is before the Dobbs decision. So we know that before the Dobbs decision, over half of people seeking abortion experienced at least one barrier to care. We know that 1 in 5 people seeking abortion reported 3 or more barriers. And we know that financial barriers, geographic barriers, and difficulty meeting basic needs are associated with presenting for care after 10 weeks gestation. And it's reasonable to assume that post-Dobbs decision, these barriers have become more impactful and more significant. As far as geographic barriers, there are now many hundreds of thousands of people living within states where they cannot receive a facility-based abortion where they live and so need to travel much farther. There are clinics that used to exist that no longer exist. Providers are penalized for practicing in that way in those states. And then this also can impact supportive states. We know that states like California have already received an influx of people seeking abortion, and we already have access issues in our state. And so we really need to think about, as providers, how can we provide care to both the people who live here and the people who do not. And so there are many ways we can think about doing this, as far as telehealth options, remote options, medication abortion, which is possible in earlier gestations. And then also thinking about training opportunities and who provides abortion. So in addition to clinics no longer existing in states that are impacted, there's also going to be a generation of physicians that are less likely to be trained in providing abortion services. And so I know that I'm in a room of many future clinicians. You don't need to be in OB-GYN to provide abortion care. There are people I've met in this path that are predominantly MD researchers who their only clinical thing that they do is provide abortion. And so regardless of the specialty that we seek to pursue, we will need more abortion providers in the coming years, because not only are we experiencing the shortage now, but we will continue for years to come. And then, of course, in addition, expanding financial resources for abortion. That includes both the procedure itself and then the transportation needed to get there. Lots of people are going to be needing to go farther distances, which means asking for more time off of work, potentially staying somewhere overnight, potentially needing a really long bus ride or a plane ride. And so needing to think about financial barriers, both as they were pre-Dobbs, but also how it's going to change post-Dobbs. And there is a lot of really incredible work thinking about telehealth options and prescribing medication abortion. And so these are also things that we should think to expand both in our state and otherwise. Yeah. So I am then gonna just want to thank all of the people who helped me in this process. My main mentor, Lauren, who was just absolutely incredible to work with and such a insightful and warm person. And then the rest of my thesis committee and readers. I want to thank the executive team at the JMP who have been so monumental in their support in the past 2.5 years. My beautiful classmates who have helped me grow and learn in so many ways. And then my family, my parents, my extended family, my partner, for all of their support throughout this process. We have some references. And then, as you've heard from classmates before me, there's a strike going on. As we do questions, we'll leave this slide up so that if people on Zoom or people in the audience want to fund the workers for like the pay that they're not getting while they strike or sign the petition to the UC president, those QR codes are here. Siavash?
That was an amazing presentation. Thank you so much. I was wondering if there was a correlation between meeting one kind of barrier and meeting other kinds of barriers, or if there were clusters of people meeting similar types of combinations of barriers.
Mm-hmm. Yeah, that's a great question. So the question is, were there clusters of barriers? So did people, for example, who experienced financial barriers and geographic barriers, do those people seem to fall together? Yes. But a lot of people experienced just one barrier, two barriers, and then a lot of those barriers would fall together. So as you imagine, we asked multiple financial questions. A lot of those went together. And there were some, but nothing particularly significant. Right on.
I know that this may be not to do with that, but I'm kind of curious how like immigration / like non-citizen status may overlap.
Yeah. So the question was if citizen status or immigration, if we were able to look at that within the sample. So we didn't have that information in our data set. And so we weren't able to look at that question. I'm not aware of work that's currently looking at that, but that would be a really interesting future area of research, particularly, in both supportive.
You're back online.
You're back online. Woo! Thank you so much for helping us fix that. It's so like above my head. Thank you so much. All right, so hopefully that was a nice little break, and we'll start again with introducing Paige Lerman. I am so honored to introduce Paige. So Paige went to Barnard College, and there she was involved in a lot of projects regarding mental health diagnosis and mental health hospitalization. And then after college, she participated in similar projects in Australia as a Fulbright scholar. Paige is such a special person to have in our program. She is incredibly intuitive, I really appreciate how good of a listener she is, which is both shown by her presence and also her ability to ask really good questions, which I know will make her a really wonderful physician and have made her a great classmate and a great friend. She is able to hold a lot of complex things all at once and different truths that might contradict each other but are yet still true. I really admire that about her. And she just emanates humility and levity in this way that I find so inspiring and so hopeful. And so, yeah, thank you so much for being who you are to me and to our program. And I'm so excited to hear your project.
Crisis behavioral health services following a mobile crisis team intervention in San Francisco. Before I forget, I have a lot of abbreviations and was thinking of my mom, so I brought a visual aid to keep everything straight. Yes. Sorry, camera folks. This will be so even as I was practicing, I was getting these things mixed up. So here are the different things I'll be talking about. Let's start with background. So there are about 7,000 to 8,000 unhoused folks in San Francisco on a given day in a given year, at least. Roughly a third of them, 36% of them identify as having some sort of mental health condition, psychiatric or emotional, and roughly 50% of them have some sort of substance use experience, and this is all self-identified. And 38% of this population identify as Black, and that's despite the fact that Black folks comprise only 6% of the total population in San Francisco. So we're seeing major racial inequities here, and already we're seeing a stage of structural racism that's influencing who is homeless and who is not. I was really interested in what healthcare looks like, and specifically what mental health care looks like for this population. We know that experiences of homelessness are psychologically taxing in themselves. We know that people experiencing homelessness need mental health services, but face a lot of access barriers to actually getting them. And we know that beyond healthcare, people who hold these identities, who are unhoused, people who have visible mental health conditions, and folks of color are over-policed. So mental health care for this population looks a lot more like crisis intervention than it does routine care. Every year in San Francisco, there are about 15,000 911 calls related to mental health, and police responders are the ones to show up. And while they do receive crisis intervention training, they're not specialized mental health providers. A lot of those 911 calls end up in people being hospitalized or arrested when specialized mental health teams could reduce those violent and expensive outcomes. And that's where mobile crisis teams come in. Mobile crisis teams are an alternative to policing. Think of them as a mental health EMS. They can have a few different kinds of mental health providers, but their common task is to show up when someone is having a crisis, and they have a much larger toolbox for supporting people outside of hospitalizing them or arresting them. The evidence for MCTs is sparse but very supportive. When someone in crisis gets help from a mobile crisis team compared to a police response or a hospital response,
they're less likely to be hospitalized from that crisis. They're less likely to be arrested from that crisis. And really interestingly, the benefits show in the weeks to months after, where they're more likely to engage in routine community-based mental health services. And all of these have a lot of cost savings. So we know that having MCTs is a promising way to connect people to care and also prevent the risks of violence and incarceration that folks of color are targeted for disproportionately. And while we have all of this as evidence, MCTs have become increasingly popular in the past few years, and every specific MCT program and implementation is different. And it's really hard to aggregate this data with people's broader healthcare use. So this study is looking at a specific MCT with aggregated healthcare use in the context of San Francisco. San Francisco's MCT is the Street Crisis Response Team. This is our first abbreviation to remember, SCRT. SCRT is actually 7 teams. They operate 24/7, neighborhood specific around SF. And each team has a community paramedic, a behavioral health clinician, and a peer specialist. Peer specialist is something near to my heart. It's a big focus of my undergraduate research. These are people with lived experience of various things who are really crucial in emotionally connecting with people during their own mental health crisis or not crisis. And in addition to SCRT providing this 911 dispatch care, they also can connect people to the Office of Coordinated Care, OCC, second abbreviation, really important. OCC is providing some sort of interim case management service where they can connect folks not only to medical treatment services, but also any social security benefits or housing centers or any vouchers that they may need or qualify for. And OCC is going to be the focus of my analysis because in addition to my research, here I've been part of the qualitative team that's had the opportunity to speak to folks who have received SCRT, and they have all said that OCC is really meaningful to them. OCC helps people feel seen, cared for, and also has resources to follow up with folks where other services lose touch. So I really wanted to know, people love OCC, who specifically is getting referred to OCC among the SCRT population, and with these positive qualitative experiences, are we seeing any reduction in people's engagement with crisis services after SCRT based on whether or not they've engaged with OCC? So these are my research questions. And to answer these, we did a logistic regression, which is basically a model to say the probability of something happen given a number of different variables. The variables that we included here are age, gender identity, race, and ethnicity. Race and ethnicity are proxies for racialized experiences in the structural racism and the direct racism that we have talked about before. And sexual orientation is excluded from our data set because there are a lot of missing numbers. And the other field of possible influences we want to know about are the features of the SCRT call. What was the reason that SCRT was called in the first place? Were police involved? And we want to know, does this impact, first, whether people engage with OCC after their crisis episode? And second, does this impact how people engage with crisis services for the month after that intervention? Here, this crisis table, which here shows the various crisis services that someone might engage with. And the ones in blue are the ones that we've included in this analysis. And the most important thing to note is that it's not just SCRT here. We want to know, after SCRT, did anyone engage in these various crisis services of any sort? Our study population comprised 1,684 SCRT recipients who had 2,700 episodes from July 1st, 2021 to October 2022. We start on July 1st because that's when OCC was implemented. Everyone in our sample was at least 18 years old at the time of their SCRT encounter, and they have linkable electronic health records that we can look at their other healthcare engagement. And they also have this observation period that we can analyze whether or not they're engaging with crisis services after SCRT. This is a bar chart just breaking down who is in our sample. We see the reddish tones are our SCRT population based on whether or not they've used OCC. And then the blue is the general unhoused population in San Francisco. We can see that the demographics are pretty similar. I'm going to be focusing on the racial and ethnicity demographics, which we see are quite similar between SCRT's population and the general unhoused population. For both of them, we see about 24-25% folks who are Black, 37% who are white, and as Jen mentioned, our data is aggregated for folks who are Asian American, despite those representing different identities, because the actual numbers are very small. And so even though there's similarities between SCRT and the general unhoused population, there's still an overrepresentation of Black folks who are using these services. So SCRT reflects the racialized composition of the general unhoused population in SF. The first question that our regression asks is who is using OCC? We found that people who are Black have an increased likelihood of 25% to use OCC compared with folks who are white. We also saw that high-intensity SCRT episodes that result in a high-intensity service setting are close to 70% more likely to result in OCC compared to low-intensity settings. And then really interestingly, because you remember a large proportion of unhoused folks struggle with some sort of substance use, having a substance use related reason for an SCRT call was associated with a 50% decreased odds of having OCC engagement. Our second regression was interested in reutilization. Who is reutilizing crisis services in the month after SCRT? And we found that most of the demographic and call feature associations were not significant, except for cis women, who were 30% more likely than cis men to have some sort of crisis reutilization in the month following SCRT. And then our golden nugget question, which is OCC associated with reutilization? We didn't find any significant association. So what that means is that people who used OCC and who didn't use OCC had the same odds of reutilizing crisis services after the fact. One other thing that I wanted to add is Black folks were also overrepresented among reutilizers. So Black race was associated with a 23% increased likelihood of reutilization compared to white. And this p-value shows that it is not statistically significant, but it's right on the cusp of statistical significance. And so I wanted to offer an opportunity to move past the heavy hand of p-values and recognize that this association, while not statistically significant, might represent an opportunity for further explanation. So takeaways and next steps. If you remember, our two main things that we were interested in is who is using OCC and what is that racial representation like, and then also who is reutilizing. We found that the OCC population is demographically representative of SCRT and unhoused folks, and that is still meaning that people of color are overrepresented. So SCRT does not exacerbate the racial stratification that we see, but it does reproduce it. And a further opportunity of research here is to actually talk to people and ask about their experiences after SCRT to understand if people who are Black are having different experiences than people of other races after SCRT in terms of why they're following up with crisis services. And our other finding is that using OCC does not decrease the likelihood of reutilizing. And the reason that it might decrease the likelihood is that if people really appreciate this type of case management support, they might be able to get connected to other services that could help them instead of having them use crisis services later on. So the fact that we don't see this outcome raises questions for what kind of measurements are meaningful in what we decide to look at for program evaluations. As we mentioned, OCC is qualitatively very meaningful to folks who use SERT. And if we were to have just done a quantitative study, we might think that it didn't matter. And so the importance of having conversations with folks about their experiences and supplementing quantitative research with qualitative research is really underscored in this outcome. And with that, I want to thank all of the people who made this possible. My mentor, Matt Goldstein, and my other mentor, Alan Hubbard, have been phenomenal supports throughout this whole process. And the whole qualitative and quantitative SERT team, Deepa, Megan, Milo, Siva, Janet, Rachel, thank you all so much. And then I wanted to thank my grandparents and my parents for being so supportive and my #1 cheerleaders throughout this process. And of course, the JMP exec team and Gustavo especially for keeping us on track, to say the least. We will miss getting emails from you every day. And to the whole JMP team, thank you for making the JMP a place to learn and grow. And of course, to my JMP classmates, thank you. Yes.
Great work. Thanks so much. Your study design gets me thinking about reutilization of emergency room services and the delay to access to primary care. Is your data set large enough to look at a day-by-day delay to sort of access to OCC and whether or not the reutilization is a linear or a sort of exponential drop-off or anything?
Yeah, that's a great question. So the question was, and tell me if I'm understanding correctly, whether there was any effect of time on people's utilization and if there was any day-to-day effect of people being able to access primary care, OCC, or crisis services after the fact. Really good question. So our data set was we initially structured our data set to account for sort of these time delays where we tried to count time from the SERT episode as a sort of exposure. And something that we found was the data structure wasn't compatible with the proper analysis methods for that. And so the answer is the data is there, but this particular cohort where it was focusing just on SERT is likely too small. This research is part of a much greater research effort. There is an amazing ITS, interrupted time series analysis going on that looks at similar questions, but for the entire population of people who are using these services in San Francisco. So not just these 1,000 folks, and they'll likely be more equipped to answer that time effect on a population level. Coco?
Thank you so much. This is such an important presentation and such important work, and I hope you make sure you publish it. The question I have is, I think it's interesting that it didn't have an effect, and I'm not surprised. It's really hard to show that. But I wonder a little bit because the people who accessed SERT are qualitatively different from the people who didn't, right? If many people who have substance use disorder were in the group that did, and people who didn't have substance use disorder were in the group that did, it might be that reasons for access to crisis care are different in those two groups, and also that the group that has substance use disorder, if connected to OCC or through SERT, would actually show that difference. So I'm wondering about if there's qualitative work on the folks who didn't go to OCC, and of course, because they didn't, they're hard to find and those kinds of things, but if there's that possibility of looking at how they could qualitatively be different than the people who were all.
Yeah, Coco asked a really good question, which is basically what kinds of things might be occurring before we start capturing data that makes it so people with substance use aren't even using SERT in the first place, or if there are certain kinds of people who aren't even captured in our initial cohort. The answer is there are definitely those kind of pre-exclusion, pre-inclusion biases that happen. And I think that's something that our broader population-based study is really equipped to handle. So that's out of the scope of this particular project, but the population-based analysis looks at all potential people who could have used SCRT, and then also compares those who did not use SCRT and those who did use SCRT and looks at those outcomes. So it's an important question that is being addressed by the bigger research team.
And the bigger research team is led by Matt?
Yes, Matt and our quantitative stars, Milo, Santos, and also everyone has their hands on different things.
And Matt's
Matt is a JMPer.
I wanted to mention that.
A great one at that.
All right. Thank you so much.
So it is my pleasure to introduce our next presenter, Justin Lopez. Justin moved around a bit when he was young, but ultimately established his roots in Sacramento, California. He is proud to call his home South Sacramento, California. He grew up along various places around Florin and Franklin Road. He is a product of investments into California's public college system, taking part in California's community college system, the California State College system, and eventually graduating from the UC system at Davis with a degree in biochemistry and molecular biology. Yeah, just let that sit for a second. Before Justin came to the JMP, he worked as a community health worker through AmeriCorps in Berkeley and San Pablo, and came back to his local Sacramento FQHC to lead WellSpace's health education program. Justin is known in the JMP for always taking care of our bodies and our wrist stretches and making sure that we're physically and mentally prepared. And I admire him as someone who is really true to his principles, both in terms of returning to his roots, mentoring folks coming from similar places, and really sharing that experience in PBL. So without further ado, Justin Lopez.
Much, Paige. Where are you? Thank you for that wonderful introduction. And thank you all for coming out to support our class. My name is Justin Anthony Mangohig Lopez. And today I'd like to share with you my work for my JMP master's thesis, Community Center Staff Perspectives on Financial Payments for Social Risk Screening, a Qualitative Study. So for this presentation, I'll share with you a little bit about my pathway to this work, some background information for level setting, and then I'll share with you my research, how it was done, what was found, and implications for the future. So as Paige alluded to, before starting medical school, I was in a lot of spaces where social needs affected health. At the Student Run Clinic, Clínica Tepati at UC Davis, I served fellow people from the neighborhoods that I grew up in, get access to medications for that they could not afford. Furthermore, just supported a large concerted effort to provide medical care for people who otherwise could not access it. For AmeriCorps in the Bay Area, I provided diabetes education, and alongside that, I also conducted social screenings and asked patients their conditions and their social contexts to identify barriers that affected their health. And when I went back to my hometown in Sacramento, I was able to serve as the supervisor for my local FQHC's health education program. And there I witnessed in depth how many non-clinical aspects of patients' lives affected how they managed their health. I also had the opportunity to work with clinic admin to integrate asking these questions into our health educator workflow. All this to hone the point that social conditions drive health outcomes. Here in UC Berkeley, I encountered many academic terms to describe these very real barriers that patients feel every day. Terms such as social determinants of health. And these social determinants of health illuminate social needs. So from looking at this figure here, there's a lot that goes into health, and a lot of that is upstream of the patient. So these are laws, policies, and regulations that lead to downstream manifestations of material needs called social risks. And these can be addressed via social care initiatives. So what are health systems doing about this? One of the things that healthcare systems are doing is to ask about these social risks in order to appropriately intervene. This is called social risk screening. And this is what I did in previous lives of mine. Social risk screening is asking patients at their point of care when they're at the clinic what their social needs are. And these are a couple of examples. So among many other needs that could be identified, health systems can ask about food security, transportation, housing, financial strength, and others. I want to just show an example screening question, and this is for food security. There can be a statement such as, within the past 12 months, you worried that your food would run out before you got money to buy more, and patients can respond to how true this statement applies to their situation. So screening has been done before, and it has been done in more direct medical contexts. I provided some examples here for colorectal cancer screening, alcohol use disorder, diabetes management, up-to-date vaccinations. There's just so many ways that screenings have been done in medical contexts. And one way that this behavior has been encouraged is by providing an incentive in the form of a financial payment or reimbursement for conducting the screening. And research shows that there are various impacts to doing this. So how could this work in community health centers to screen for social risks? And that leads us to our research question. What are community health center staff perspectives about financial payments for screening? So how do community health center staff feel about financial payments for screening? Could this work to change clinical behaviors? This question is evaluated as part of a larger study, the CRISP study, comparing implementation strategies for social needs programs, a natural study of 2 pragmatic trials. So as mentioned, in the study, 12 Oregon-based community health centers participated in one or more of the following programs, which is AHC and Ascend. And basically, AHC is a program where financial payments were introduced per social risk screening and referral completion. Essentially, health centers were paid to conduct screenings and to link patients to support. Another program to increase screening behavior was called the Ascend program, and community health centers were provided rich technical electronic health record support. So again, this study looked into clinics participating in either program or both programs simultaneously. So to conduct the study, staff at various levels were interviewed: administrative leaders, clinical providers, clinical staff. And these interviews were conducted between November 2020 and December 2021. These transcripts were qualitatively analyzed in 2 rounds. So the first round involved developing codes to organize and get a general sense of this data. And where I come in the second round, it involved a deeper analysis of the 41 transcripts into codes related to financial and material support and recommendations for improving screening and the referral process. At the end of the analysis, the data was grouped into 4 domains: participant awareness for financial incentives, design elements of the incentives, perceived impact of financial incentives, and design recommendations to maximize the impact of these incentives. And from these 4 domains, we are able to find some noteworthy findings. Firstly, it was found that even in clinics participating in the AHC receiving financial incentives, clinical staff and clinical providers were unlikely to be aware of the financial incentive program. So if staff weren't aware of these, certainly these were not working as incentives. In clinics with no financial incentives, staff were similarly unaware the status of whether they were receiving a financial incentive or not. Also, through the interviews, staff touched upon design elements where the money went. CHCs were receiving multiple streams of income. We funds together to create this thing called a patient flex fund. And that patient flex fund was used to pay a significant portion of a patient's electricity bill, for example. Some clinics had money go into hiring more staff. And for some of the interviewed staff who knew the clinic received incentives, some of the staff just didn't know where the money went and how it was utilized. So overall, people didn't really think financial payments would change behavior to increase screening. There were a lot of perceptions of the barriers for the positive impact of financial payments. Some of them were due to poor workflow, some reported lack of time, and low monetary amount. Interestingly, another reason given by participants was that incentives weren't even necessary. And they stated that because of the clinic's mission was to already screen and address social needs, and the passionate characteristic of what it is to be a community health worker, this did not require incentivization. Lastly, when interviewed, participants provided recommendations for maximizing the impact of financial incentives. Across all levels of staff, they indicated that they wanted incentives to go directly to patients. In the same lines of benefiting the patient, some of the staff indicated that they wanted the money to go towards increasing capacity, such that the capacity to serve patients increased. So, of course, this study had a couple of limitations. For one, the study is in the context of community health centers. Although present in rural and urban settings, all of these health centers were in the state of Oregon. And even though a wide range of staff levels and positions were interviewed, convenient sampling occurred as the interviews depended on staff availability. Nonetheless, this was the first study of financial payments, and social risk screening, and there's more to learn in the future. In fact, in 2 months, we'll be receiving data on outcomes. Remember, this study is based on perspectives. So we'll be able to compare and contrast these findings with actual numbers. So overall, as designed, the AHC incentive did not work to incentivize the change of behavior. Staff responsible for screening were largely unaware of payments for social screening, and staff at AHC clinics aware of payments did not see them as having impact. However, from these interviews, we learned that direct payment to patients may motivate social screening, and this was shared by staff regardless of if they had an incentive program or not. All in all, this is to say that incentives for social screenings are fundamentally different than clinical screenings. Money and design considerations for designing incentivized social screening programs should be different than that of designing clinical screening programs. We don't have to throw the baby out with the bathwater, and we don't have to scrap incentives altogether. We can find ways to align financial incentives with the community health center mission. Providing something very concrete to patients, such as money or increased services, may help staff overcome the screening uptake barrier of fear that they aren't doing something for the patient. And that misaligns with their understanding of their role in the community health center. I just want to share this quote here that a community health worker shared with us. For me, it's just being able to impact patients more directly is what I would want in a perfect world. Now, this study and its findings are very timely, as the National Committee for Quality Assurance, the NCQA, and the Centers for Medicare and Medicaid Services, the CMS, they have new plans starting in the coming years, which introduce quality measures for social risk screening. So basically, these are programs that pay for that act of social risk screening. So research like this, research on how financial incentives can be designed and implemented to meet social needs in these health settings, can inform how institutions design the recommendations for incentive schemes. Thank you. I want to give a bunch of acknowledgements. I want to acknowledge my thesis committee, Laura, Susan, and Coco for agreeing to take part of my committee. I want to acknowledge Gustavo just for all the work that he's put in coordination for all of our masters. I want to, yes. I want to acknowledge the CRISP team that I worked with. Some of those members are here today, so thank you, Laura, for coming out and supporting. Holly, Danielle, and Sarah. Grateful to the team at Ochin for being UCSF Sirens collaborator in this CRISP study. I also want to acknowledge just all the staff here at the JMP that have impacted me and many more than is listed out here, and also my classmates for making these years truly enjoyable and such a growing experience. And lastly, I want to acknowledge my family members, my grandma, my parents, my friends I made along the way, mentors, and my partner. So with that, I'm very happy to take any questions. Yes?
When you mentioned social risk screening, does that include asking about domestic violence, or is that under a different umbrella?
So so the question was, when I mentioned social risk screenings, was domestic violence part of those considerations? And yeah, the the thing about social risk screenings is that this is a very new field, and a lot of the questions that are asked are not standardized. There are certain recommendations that are given out, and for this particular study, the question, it fell into 5 domains, and yes, interpersonal violence was part of those questions. Oh.
You can take the question from the middle, that's all right.
Yes.
I'm curious if you have an idea of whether like fear of CPS involvement could have any incentive or like bearing on folks' willingness to engage in any of the social screenings or any of the other screenings.
That is a great question. Within the literature, so the question was fear of CPS a barrier at all into doing social risk screenings? That is a very good question. There are a lot of barriers when it comes to providers' comfort levels when it comes to asking these questions. So, you know, certainly in the interest of the patients, we've seen in literature that there are fears that providers have. I haven't read any literature particularly about CPS, and that is a very interesting direction for research. Liana.
Hi, Justin, great work. I had a question if you have a sense of what the implications may be in sites where the health workers or that clinic is not internally motivated, right? Because some of the responses we got here was that the incentive didn't work because everybody who works here wants to do the right thing and just wants to do social screenings for intrinsic value, and whether you had any sense of what the implications might be in clinical settings where maybe there wasn't, or is the implication that all health workers just intrinsically wanted to do the right thing?
So the question is, did I encounter, if I'm getting this correctly, did I encounter at all if the main theme was that people in health centers had this motivation, had this altruistic motivation to conduct screenings, and were there any instances of addressing like internal lack of motivation? That is also a very good question. I think there were other barriers that could exist. In the community health center setting, there's a lot of staff turnover, and particularly in the interviews, a lot of staff mentioned that, hey, this work does not pay that well. And for me to keep going, I need that sense of purpose that I'm actually going out and helping the patients directly. Further research can be looked into how in health centers, how programs are communicated, how top-down communication is conducted, and that would be very interesting. I mentioned before that there was a little bit of convenience sampling, and folks who were interviewed basically had the availability to be interviewed, so that could definitely intersect with the amount of motivation a participant can have.
Thank you so much. Thank you very much. That concludes our session in the morning. We now have want to offer some recognitions. So I want to begin first by thanking all the mentors, co-mentors. And in the format that we're currently using, we have now a reader for the papers that our students are presenting. And I want to thank also the readers. That means that essentially all students have submitted their papers and they're in the hands of the readers at this point. So pretty much we're wrapping it up. And that's wonderful. I also want to thank the faculty in the master's program, and particularly Susan Ivy, Susan is the champion of all the students and also has been my partner in helping me get all our students that are finishing today getting to this point. So that's thank you so much. I want to next thank Michael Schoenbeck. Oh, he just left out. He's our wonderful librarian. I wish he had been here for this special meeting, but Michael has been instrumental in supporting all our students in getting their literature searches right and keeping their literature updated and all of that. So we are so thankful. He's such a great partner to our program and our students. And we do have one final award that will be presented by Liana Lewis, our wonderful co-director. Right after Liana introduces this award, we are going to break for lunch and I ask you to please come back right before 1 p.m., okay? Yes, you are.
How are y'all holding up? You get to ask that in the room. On YouTube, I have no idea how you're holding up. So I hope you've taken some breaks. So first, want to just say on behalf of the program in medical education for urban underserved, our Prime US community, want to really acknowledge all the JMP students and all of your work, and certainly the 4 JMP Prime students who will get a chance to share their work today: Justin, Ria, Vishali, and Jessa. I'll let you know how much your Prime family appreciates, admires, and respects you, and is here either physically or online. So just want to say that. And in that very similar spirit, it is my privilege to share the award for appreciation for research mentorship with Dr. Laura Gottlieb this year. Dr. Laura Gottlieb is a prolific researcher. Probably the only thing she does more prolifically than research is email and answer emails. She's the most prolific, efficient emailer and text message you will ever meet, and is the reason why I get to be here at the Joint Medical Program, and I've been a part of this program. And her support of students across, throughout, and over many years at the JMP is phenomenal. What I can say about Laura is that the answer is always yes. So if you send a JMP student Laura's way, no matter what their topic or interest, you can guarantee that she's going to say yes. And that has made a huge difference in the lives of so many of our students. And she says yes, no matter where it is in the moment, whatever it takes to make it happen. And the rest of us, I can say as administrators, know once Laura says yes, we don't have to worry about it again, right? Like the research done, the student is well mentored, well guided, and is held throughout the process. And so there's not a person, who is better deserving of this award, but I also appreciate just the opportunity to tell a friend and a colleague how much I appreciate and admire and respect her. And on behalf of all of us at the Joint Medical Program and your Prime family, because Laura Gottlieb is the former Prime US Director here at the Joint Medical Program. Thank you for your service. Thank you for all that you do for students. And personally, thank you for gifting me the JMP. Because I just don't know, right? I'm not here without you coming into my life in this way. So come up and let us say thank you. And I don't know if you get to say words or online. I'm not sure if online you get to hear anything. I have no idea what happens next. I have a mask on. I don't care. So much appreciation. These are yours, and you can either say a few words or someone's gonna make you stop talking. So.
Is Gustavo gonna send me an email?
It's better say urgent.
Yeah, urgent, lunch. I don't know what to say. I'm so flattered and honored, and I will just say, I guess, Josie told me I had to come, but she didn't tell me I was going to cry. I'm going to say two things. One is, I really, really feel like every student at the JMP that I've ever worked with has taught me more than we have ever taught them. And I'm constantly encouraging my friends to mentor JMP students because it's so rich and it's so important, and what you guys are doing is going to change the world. That's first. And then the second thing, I forgot. Of Hollywood and the amazing research team that we have at Siren, and just like no mentor is ever mentoring by themselves. Everybody, it's the student, it's the team. Research is a team sport, and I just really, really want everybody to recognize like there is no one mentor who gets an award. It's everybody who gets an award on that team. So that